p.m. tonight. It's not just a tornado, it's a heavy rain combination of all.
Janet? Is Janet on the call?
Yes, ma'am. We have 6 people, I believe, so far.
Is 6? I counted 5. Do we have a quorum? We have a quorum, right?
Well, I counted Manson, but I don't think he got on.
Oh, okay. I think,
Oh, he is on. Yeah, Manson.
oh, there's Mr. Manson. Yeah.
We got Manson, Burley.
Okay.
Higgins,
We have
Manson,
Burley,
Robertson.
Bagans, Manson, Robertson, Stevenson, Sullivan. I know Alex Fisher was going to have to leave by 5 o'clock. I'm not sure if she's coming over or not. And I know Dr. Slovis is not going to be on tonight.
Okay,
So, Ranga is the one I'm missing.
so we're waiting for him.
We have a quorum though.
Okay, well, let's start.
It's 5 o'clock.
Do we have a quorum?
We have a quorum because we have 6 people on.
Okay, well, let's start. We're good to go?
Yes, ma'am.
Okay, so I want to welcome everyone to the March 25th, 2021 Nashville General Hospital Authority Board meeting. Thank you all for joining us today. We'll go ahead and get started and call the meeting to order. Please make sure you mute your phones or computers if you're not speaking. At this time, I'd like to entertain a motion to approve our electronic meeting. Someone can read from the agenda. Manson?
Yes. I move that the items on the meeting agenda constitute essential business of this board. Meeting electronically is necessary to protect the health, safety, and welfare of Tennesseans, considering the COVID-19 outbreak, and any rule that conflicts with governor's executive orders permitting electronic meetings be suspended.
Okay, can I get a motion to, or entertain a motion to approve our electronic meeting?
I'll second.
Okay, second, yeah. Any further discussions?
Madam Chair, would you like for me to do the roll call?
Sure.
Okay, Burley,
Here.
Fagans.
Here.
Okay, these are for the approval for the electronic meeting, so it would be aye, correct?
Okay,
Aye.
Thank you. Manson,
Aye.
Rhonda,
Aye.
Robertson,
Aye.
Stevenson,
Aye.
Sullivan.
Aye.
I'm sorry, is Sanders on?
Fisher.
And Fisher's on now, right?
Yes, aye.
Okay, thank you. I'm sorry. Reverend Sanders is not on, correct? Thank you.
Okay, so are there any further discussions? If no discussion, all ayes to approve the electronic meeting.
We just did.
Oh, I thought that was just a roll call. Okay.
No, that was it.
Okay, all right. So hearing no nays or abstentions, the motion carries. We'll move on to the conflict of interest. Derek Smith.
Yes, Chair Dr. Fagans. Just as an introduction to this this discussion item, it's new to the agenda. And just to inform, this is something that other boards and commissions within Metro, some offer this to the board and commission members as an opportunity to announce whether they may have a potential conflict of interest and make an announcement too, whether they believe they can remain objective and unbiased and therefore not need to recuse themselves. But if they question that, they're able to recuse themselves from those matters. Not to mean that if it came up during the meeting that precludes you from, upon further reflection, changing your mind, but it's something at the beginning. Also, just to let the board members know, as counsel for the authorities board, I'm available for discussion in advance of meetings. If you, in reviewing the board's business and packages, determine that you would like to have questions that you may have addressed, you're able to reach out and discuss conflict of interest issues with counsel. Also, if during the meeting, of course, I would have to express opinions publicly if you ask during the meeting about a conflict of interest, but I'm available for that as well. So with that introduction, just so that you all know that it is on the agenda and what its purpose is. And thank you, Chair Dr. Fagans.
Okay, thank you, Derek. So we'll move on to the minutes. So our next order of business is to approve the hospital authority minutes from the February 25th meeting. Are there any corrections or additions to the minutes of the February 25th meeting? There being no additions or corrections, I'll entertain a motion to approve and second the minutes of the February 25th Hospital Authority Board meeting.
Move approval, Madam Chair.
Okay, thank you, Manson. Can I get a second?
Second from Robertson.
Okay, thank you. Any further discussions?
Are you ready for roll?
Yes.
Okay, thank you. Burley,
Yeah, I forgot.
Aye.
Aye.
Fagans,
Aye.
Fisher,
Aye.
Manson,
Aye.
Ranga,
Aye.
Robertson,
Aye.
Stevenson,
Aye.
Sullivan.
Aye.
Thank you.
No nays or abstains? All right, hearing no nays or abstentions, the motion carries. We'll move on to old business. Is there any old business that needs to be discussed? All right, we'll move on to new business. Any new business? None? Okay, let's move on to medical staff credentials report. Burley, you have the floor. Is Burley still here?
He's muted.
Yeah.
Oh, you have to unmute.
There we go. Had to get it off mute.
Okay.
All right. Yes, we have a brief report, actually. We had approximately, it looks like 1, 2, 3, 4 additions from provisional to the active staff. Let's see, we have Amy Price Neff, MD, that's in the family and community medicine. Brady Harris, MD, in surgery. Matthew Katz, also in the Department of Surgery with a specialty in ophthalmology, moving from provisional to active. And Leanne Thomas, RN, FA in the Department of Surgery, also moving to the active status. And we had 3 reappointments, all in the Department of Radiology. James Fernandez, Robert Watts, and Curtis Tedesco. And I would ask that these individuals' changes in status be approved.
Okay, thank you, Burley. Are there any questions regarding the medical staff credentials report? All right, hearing no questions, I will entertain a motion to approve in a second the medical staff credentials report.
Motion to approve, Fisher.
All right,
Second, Ranga.
thank you. Any further discussions? Okay, we can take roll.
Okay, thank you. Burley,
Yes.
Aye.
Bagans,
Aye.
Fisher,
Aye.
Aye.
Manson.
Aye, I'm sorry.
That's okay. Ranga,
Aye.
Robertson,
Aye.
Stevenson,
Aye.
and Sullivan.
Aye.
Thank you.
All right, hearing no nays or abstentions, the motion carries. We'll now move on to the finance report. Naramore?
Thank you, Madam Chairman. I've got January and February financials to report, and I'll try to do them quickly. We spent quite a bit of time at Finance Committee reviewing these.
Question, are we gonna vote on those separately after each report or together? Or does it matter?
We did them separately at Finance, but I think you could do them as a pair.
Oh, I'll combine, okay, thank you.
All right. So I'll go January 1st. 1 second. There you go. There you go. Thank you, Sharon or Janet. Okay, our January financials. We had 164 admissions, which was a decline of about 10% from the prior month. Our observation admissions were higher than prior month, still below budget for the month. Patient days were well above budget, primarily driven by a very extended length of stay. We did have quite a few COVID patients in the house in the month of January, although that's obviously subsided recently. So our length of stay drove the number of patient days for the month, and you'll see later it also drove our inpatient revenues much higher than budget. But we continue to see emergency room visits running anywhere from 25 to 30% below budget and pre-COVID days, which is impacting our ER revenues, outpatient imaging revenues, and observation revenues negatively versus budget. The inpatient volume has been steady. So you can see our clinic visits were 17% above budget in the month of January, a good solid month. But surgery, again, flat to slightly down from December. And the cath lab obviously well above budget, although behind prior month. Deliveries were slightly behind budget and slightly behind prior month. And then down at the bottom, you see the hospital case mix for Nashville General. Whenever we have a case mix over 1.4 or 1.5, that indicates that we've handled a dominant number of high acuity patients in the hospital. And the COVID pandemic certainly has had a big impact there for us. So next, please, income statement. So this is the month of January. Our inpatient revenues, even though our admissions were slightly behind budget, the intensity of the services in the inpatient setting was well above budget. And so our inpatient revenues were actually 22% higher than budget. Our outpatient revenues were significantly below. The ER volume, certainly the biggest driver there. And then our procedural areas, the surgical areas, are still not achieving budgeted thresholds. On the net patient revenue, we did achieve almost 20%. So you see, out of the $21.4 million of gross revenue, we harvested 4.2 million, which is actually 348,000 better than budget. And that's driven by the last 3 months. The hospital has had extremely good patient collections, averaging roughly $5 million the last 3 months. And when we start collecting at those high levels, we have to start reducing our reserves, which means our net patient revenue percentage is going to rise. And that's what you're seeing here. So $21 million produced 4.2 million net. The other items that you see in here that are favorable, $380,000 favorable variance on our essential access. That's state and federal dollars that we receive for DISH and essential access as a safety net hospital. It's been running better than prior years and budget all year. I do think that that's related to COVID and the state and feds trying to pump money into the hospital systems, but it's a benefit for the hospital. And for the year, you can see that we're well over $2 million ahead of budget in the essential access revenue line. And for the year, for the month, $9.3 million of net revenue against a budget of 8.7, so significantly better than budget. We did not draw down any CARES Act money in the month of January. You will see that we drew some in February. We also had our salary costs were well above budget, about 400,000 higher than budget. The majority of that is providers that we brought on in the hospital and that were not budgeted at the time, general surgeons, orthopedic surgeon, urologists, and such under the employment of the hospital. So that's driving the salary numbers there. And then you can also see contract labor, again, is still high. It's down from last month, 476,000 last month, down to 408 this month. And you'll see in February, it's down to about 350. That's definitely trending in the right direction. Nurses are returning to the state of Tennessee that have been traveling, working around the country. And I think that's, we're benefiting from that. We're seeing not only availabilities going up, but the rates per hour for contract labor are returning to some relevant normalcy. We had seen ICU rates for nurses that went from $66 at the beginning of the pandemic to $120 in February. And so that's driving a lot of the contract labor. It's not the number of hours, it's the dollars per hour that are required. So those are probably the biggest impacts on the hospital. Contract services are up against budget, 2 primary items. We brought up in-house radiology, and so we're paying a contracted service there for our radiology services. We will collect the professional fees for that service. It will probably ultimately net to no impact once it's fully up and operational and drawing cash. But the other one is the security contract that used to be the responsibility of the sheriff's office. The hospital had to take that payment over. It's roughly $80,000 a month. It was not budgeted, and it will impact our budget for the remainder of this year as well. So our total expenses were 1.2 million higher than budget in the month. We did not draw any CARES Act money to offset expenses. And so we suffered a loss of a little over 600,000. Our budgeted loss was basically 50,000. That's for the month of January. And if you cross all the way to the right, you see year to date, that loss of 600,000 actually brought the hospital slightly below the watermark. We had been break even prior to January, and now we have a year-to-date loss of $570,000. So those are really the income statement for the month of January, and balance sheets and accounts payable. And I think we gave the revenue cycle report for January last month, so we're gonna move through and do February finance, and then Christine will do a brief revenue cycle report. So here's the financial report for February. Again, volumes basically steady in a 28-day month instead of 31. But as you guys are all well aware, the hospital, all of our outpatient services, our clinics, our elective surgeries, for that week of Snowmageddon, we suffered. Our ER volume dropped to very small numbers. Our procedural areas basically were closed, and our clinics were closed basically for 4.5 days of that week. So it affected all the numbers in February. Patient days were about on budget, down a little bit from last month, benefited by our length of stay finally dipping back something sub 5 days, closer to our budgeted and historic levels of about 4.5. Emergency room visits, only 1,500 visits last month. Budget was 2,500, and prior obviously was almost 2,000. Even in January, the basically week of closure obviously had a significant effect there. Surgical volumes, again, they were basically steady with last month, but still lagging a bit. Elective cases are just down post-COVID. Those hopefully will start to recover as the recovery from COVID in the area continues to improve. Our case mix, again, 1.67 is still a good number for this hospital. It reflects less acuity than you saw the prior month, but continuing to show higher acuity patients being managed in this setting. We have interventional radiology full-time. We have interventional cardiology full-time. And so once the surgery numbers continue to improve, I expect that case mix number will continue to go up for the hospital, which is a benefit for us financially. Next, please. So for the month, you can see that our inpatient revenues, again, were about 20% above budget. That was mainly due to the intensity of the service. A lot of ICU patients still in the month of February. Our outpatient revenues were well below budget. Again, the emergency room running 40% below budget was a big driver. Also, the number of observation visits as patients in a bed, but in an outpatient setting, that revenue has been down pretty substantially, particularly with the snow week that we experienced. Net patient revenues, again, almost 20%, because I have to keep dropping the reserves because the collections, we estimate collecting 4 and then we collect 5, and pretty soon you have to start reducing your reserves accordingly. So that's what's reflected here. So even though our revenues were a little bit below budget at gross, we were actually 300,000 better than budget on our net patient revenue line. We did draw down about 200,000 of CARES Act money reflected in the other revenue line here, which was a net $185,000 benefit. And then our essential access and dish dollars were about $1 million, a little bit above budget. And so for the month, the hospital had about a $600,000 favorable net revenue line. On the expenses though, again, 430,000 negative on the salary line. Contract labor is dropping, but it's still significantly above budget. And then our contract services are up because of the radiology contract and the security contract in particular, driving that number. Eventually, we'll collect most of that radiology dollars back through the pro fee collections that are our benefit at the hospital. So all in, we had about a 1.3 million negative variance on expenses, and that produced a month, again, of another $600,000 loss compared to a $60,000 profit, which was the budget for the month. And you can see year to date, the January, February months, that $1.2 million operating loss for the year to date. It's substantially behind the budget. It is still 2.2 million ahead of prior year performance, but that's where we stand through the first 8 months of the fiscal year, Madam Chairman. Any questions?
Bruce, it's Ranga. First of all, thank you for the reports. I just had a question. You mentioned that salaries went up by $400,000 because we brought in people. So could you just say more about what that was about? Because, and help me understand that in the context of decreasing volumes across the board. Yeah.
Sure. Ranga, last year at this time, you know, I don't want to speak badly, but we were having a difficult, you know, we need 3 full-time general surgeons just to cover call here in the hospital. We need, you know, 3 orthopedic providers in order to sort of basically cover call in the hospital. So, you know, Meharry was having trouble or declining to fill those spots. And so the hospital did undertake to bring those physicians on through significant recruitment efforts to get 2 general surgeons in-house, 2 urologists in-house, 2 full-time ortho doctors in-house, a podiatrist, an interventional cardiologist. I mean, those are all fairly high dollar specialty physicians that we brought on. Last year at the time that we did this, we were not exactly sure whether we were going to be successful recruiting and whether, you know, the Meharry Nashville PSA agreement, et cetera, would allow that. But we had to do what we needed to do for patient care. And, you know, the good part is we were able to recruit some of these spots, but, you know, surgeons are expensive, interventional cardiologists are expensive. They were not budgeted because we didn't have certainty at that time that we were going to be successful bringing those physicians in. And we got them in and COVID hit. And so I do suspect that if you went back and looked at our first 8 months before COVID last year, you would see that the hospital was on a ramp up of about a 10% increase in volumes. COVID hit and we went minus 30% just that quickly. And so timing is unfortunate, but we brought on some very high cost specialties at the very time COVID hit, and they were not budgeted. So, you know, not picking any names, but if a surgeon is $25,000 a month or $30,000, and the support staff is maybe another 15 for that surgeon, you're talking about $50,000 for every provider net new that we brought on last year. That's what I was referring to when I mentioned that those providers are driving the bulk of that salary increase. I will say we did have a 3% annual increase for our full-time employees in January, which does produce about $110,000 of that increase. But the bulk of it is providers that we brought on by necessity because we are the safety net hospital and we have to provide those services to patients, or we spend more money sending them out. Or if they're uninsured, they may end up going without care if we can't provide the surgeon here at the local safety net hospital. Does that answer your question, Ranga?
Oh, yeah, it does. So to me, it's a recurring monthly negative variance now.
It will be. Obviously, they'll be budgeted. They're budgeted in my 2022 budget.
That's
yeah, they are budgeted for next year. It's not like it surprised us. It's just, I typically don't budget something that we're not sure if we're going to bring that service on or not. That's just.
Okay, that helps. Thank you.
Okay, thank you.
I have a follow-up question on that. This is Michelle. Do you then also have the collections as an offset somewhere in here?
Well, we have net patient revenues, Michelle. We don't actually put collections. We do have a revenue cycle report that's coming in just a minute. If you want to hang on just for a minute, you'll see that. So we do have collections. It's in our revenue cycle report. We don't report collections on the income statement because we report obviously on accrual basis.
I was referring specifically to the providers, if the provider salary was included as opposed to it being otherwise what I would assume would be in contract or physician services.
Right. No, the collections are in the patient, the 3.8 or 3.6 million that you see up there. Our provider collections are included in that number.
Thank you.
Okay, thank you.
And Bruce, are we charging the Sheriff's Department for their patients now?
I'm sorry, are we charging?
Sheriff's Department's patients?
We are not able to charge the DCSO patients. So not at this time. We're not. Those are still done gratis.
Okay,
We charge, we're not paid. I guess maybe I'll be more specific. We do charge for them, but there's no reimbursement associated with them.
wasn't that an offset to the security we used to do? They used to do?
I believe, I wasn't here for all that, Joel, you may have been. I believe that was part of that in the old days when Nashville General was a full part of Metro government. You didn't want to pay things between Metro agencies typically. And I think it's really more of a vestige. It's an intergovernmental agreement, even though we're really not directly a part of Metro government. We sort of got the bad end of both of those. So we're providing the service now for free, but we're also paying for the sheriff's service that used to be free.
Okay, thank you.
Sure.
Are there any further questions regarding the January and February financials? Okay, hearing no questions, I will entertain a motion to approve in a second the January and February financials.
This is Stevenson. I move for approval.
Zachariah Seekins.
Can I get a second?
Burley with a second.
Okay, Janet, you want to take roll? Or any further discussions? I'm sorry, any further discussions?
Okay, are you ready?
Yes.
Okay, Burley,
Aye.
Fagans,
Aye.
Manson,
Aye.
Rhonda,
Aye.
Robertson,
Aye.
Stevenson,
Aye.
Sullivan.
Aye.
I just want to note that Ms. Fisher had to leave, so she was not present. Thank you.
Is that everyone? Janet?
Yes, ma'am.
Okay, so hearing no nays or abstentions, the motion carries. Now we'll hear the revenue cycle update from Crowley.
Hey, good evening, everyone. On the first slide, we're looking at our cash collections, and you look at the trend, we have a consistent 10 months of just very positive meeting and excelling against our stretch goal. And we set a record in December, still met the stretch goal in January, and February set a new record there. So the cash has been very positive. That's been a response to a lot of team effort across the organization. And the next slide looks at our unbilled. We have had a goal to reach and maintain below 5 days of accounts receivable in unbilled status. And finally, you can see that trend line, and we've been talking about it for months. We finally made it below 5. We ended at 4.99 for the month. And so far this month, we're running real close to that and hope to do at least 2 months in a row, making that stretch goal. The next slide is on new denials, and they are up across the industry. Denials are up, both administrative and clinical denials. I'm reading journal articles and have confirmed that with Parallon and HCA, that denials have just been going up for 3 or 4 months in a row. So that's what we're experiencing too. The number one area that we still continue to have denials in is in authorizations. And we have several different teams that are working across the organization from clinic and hospital that are helping to push that down. The second area is medical necessity in general, an area that would be in status, inpatient versus observation. And those, again, are industry trends, and we're experiencing it as well. We do have 2 new patient advisors who are helping us with case management and utilization review to take such activities as peer-to-peer reviews that will help push those high dollar reviews down. We had 3 over the last couple of months that were denied in entirety because it wasn't challenged. And that was a lot of money for the hospital to lose. The next slide is our accounts receivable over 90 days. This is just third party or insurance receivable. It does not include self-pay. Our goal is to be at or under 25%. And we finally made that goal this month. We're very happy about it. Came in at 24.6%. And that again has been effort of several different teams that are working from the back end in the billing cycle and pushing information upstream in the revenue cycle to charges and reconciliations and all those things we need to do to collect in full and collect as timely as we can. I do not have a slide for the professional side this month. I apologize. It came up before I could get it prepared. I do have the numbers and it will be in next month's report. Our cash for professional billing was $119,000 last month. Our revenue was down because a quarter of the month, that full week that we were closed due to the snow and ice. So our revenue was below $600,000, which was extremely low. Very good news for denials on the professional side. We remained under 1% of any new denials that were written off in the month. Are there any questions?
All right, if there's no questions, we'll move on to the CEO contract. Manson?
Don't we need to have approval of those minutes?
It said information.
Okay.
Yeah.
The revenue cycle is information, and you already endorsed and approved the financial statements. Thank you.
Okay, great. Sorry about that. Thanks.
Madam Chair, this is the report of the ad hoc committee of the Hospital Authority Board. It was a committee that you assigned, which consisted of Alexandria Fisher, Richard Manson, Dr. Bonnie Slovis, and Pastor Frank Stevenson. We did meet on 2 occasions. I would like to submit as part of my report the minutes of the February 26, 2021 meeting, and that they be a part of the record. Without going through all the details, but I will say that we did a thorough investigation based upon information that was provided to us from HR, but also information that was provided to us independent of them. There were numerous questions that were asked in reference to the compensation that we have presented, the compensation that we have given our CEO leading up to what his current contract is, and the fact that he is now available for a new contract based on the expiration of the previous one. Again, we evaluated this based upon information that we was provided, and this is the recommendation for this committee. We are recommending a term contract of 3 years. The compensation that he currently is earning, and that we were given a number, his current compensation, if in fact he meets all the requirements based on the audit that was conducted, should be approximately $479,000. So at the end of his contract period, his base salary will be $479,000. But we also want to keep in mind that he receives an additional 30% of that salary as a matching for his retirement. So based on that information, we determined that his total compensation is approximately $553,000 based upon the 30% retirement compensation. That being said, we're recommending again the 3 years, that his base salary now will be based upon whatever that ending compensation is based upon the contract he currently has. We continue the 30% deferred compensation through his new contract at the same 30%. His insurance, vacation time, and current benefits to be continued and will be consistent with what is now currently offered to Nashville General Hospital employees. The additional compensation award will be based upon a 5% incentive payment and a payment based upon what everybody else at Nashville General Hospital is determined to receive based upon cost of living. So his additional 5% incentive payment, and that's something that we've got to work on with HR to determine what represents him meeting the 5% incentive payment addition to his current base salary plus the 30%. That is our report, Madam Chair.
Okay, are there any questions regarding the report?
Mr. Manson, so this is Ranga. So thank you for the report. So I've been on the board for about a year, so some of this could just be historical context that I need to be, I'm not familiar with. But this increase to 553 as the base right now,
Yes.
how is that linked to performance? So I'm just trying to get a sense.
Right now, his current contract, he has an opportunity, in addition to his base salary, to earn 10%. 10%. So it was 5% that was the cost of living, an additional 5%, okay, which was based upon numerous things that were set out in his contract, such as getting the PSA signed, and various other things that were that were involved in his contract. So that's how that 10% was earned, and it just sort of accumulated. That became his new base salary.
Okay, great. Thank you.
So if he would, so if he was successful in those two areas, then his base size would increase 10%. That would become his new base, and then everything else would be based upon that.
So this would be the maximum allowable increase as per the current contract. Is that correct?
Well, what we're proposing is that whatever that final number is, which has to be determined based upon him meeting the requirements and the incentive. We speculate based on the report from HR that base will be $479,000. So that contract, the beginning amount for the contract will be $479,000, and he will be able to receive whatever the cost of living is for other employees at General Hospital, and plus an additional 5%. And that 5%, we've got to set out a matrix to determine what those things are going to be based on, whatever the goals that we set as a board, he needs to achieve.
So again, I'll ask one other time, so maybe I'm slow to pick it up. So the conclusion is that 10% represents the maximum possible increase subject to certain performance expectations being met. And the assumption here is they have been met for the past term. Is that fair to say?
That is correct. Okay. Yeah, that is the assumption.
And is that based on any of the board committee's assessment? I know there was another committee that did a performance review.
I believe it's based upon what we looked at. Well, we can look at what has happened in prior years where he actually received it, and the hospital still is performing at the same level. And I believe that he met all the requirements that the board set out. They were not very, we want to do a better job, sort of listing what those incentive payments are going to be based upon that 5%.
Great, thank you.
Mm-hmm. Mr. Manson, this is Joel Sullivan. The questions I have, what is his current base pay?
His current base pay, without the current incentive that he's going to get,
right,
it's $426,000.
Okay.
It's where he is right now, but that does not include the base that he's going to be entitled to, at the end of whatever this year is, when that occurs.
But you're estimating that to be 479.
We're estimating that it's going to be 479.
And if I understood the question that Rhonda asked was, will he meet all the incentive for the extra percentage, the requirements the board set forth? I know one of the requirements, I don't recall all of them, but one of them was getting the agreement, PSA agreement signed, which has not happened.
Right.
So I don't think he's going to meet all the requirements that were in that performance incentive.
Well, that's why we said it's just whatever that number is based upon the starting salary will be based upon current ending salary at the end of the current contract period, which we estimate to be 479.
When does his current contract end?
That's correct.
When does it end?
The contract ends this year.
So June 30.
June 30th, yeah.
Okay, thank you, sir.
Mm-hmm.
Smith, this is Michelle. I'm having a hard time finding the document with this information on it. Was that included in our packet?
It was not.
Okay.
This report will be added to this is our report, which was requested, by the chair, that we activate an ad hoc committee. And the ad hoc committee, based upon information that we were provided by HR, as well as an independent salary compensation firm that looked at compensation not only for, we narrowed it down to safety net hospitals, not just hospitals in general. So we asked them to go in and look at this specifically related to safety net hospitals. And all that information was reviewed by the ad hoc committee, and this was a recommendation to the board.
Question. Manson?
Yes.
So does Metro give cost of living raise every year to their employees, or?
No, I don't think it does. I'm not sure. But if they don't, if Metro doesn't give one, then he doesn't get one.
And what percent, when they do give them, do you know what percent that is usually?
Well, he could earn up to, the way it's set up, he could earn up to, the max he could earn up to would be 5% in the cost of living.
That's
so
based
if
off
Metro got 2%, then he would get 2%.
Okay. But he may not necessarily get the cost of living increase every year.
Only if the other employees of Metro get it. The only thing that's going to be guaranteed from an incentive standpoint is based upon the criteria that we set as to whatever those matrices that we determine, from year to year. Like Joel said, one of the determinants was, well, we need a PSA sign. Well, there may be some other things that the board feels are very important about how this hospital needs to progress to be incentivized based upon the payment. So it's just not going to happen. We've got to set some criteria, some standards for that.
Yeah, and I'm just not so sure about that cost of living increase, especially if Metro doesn't give it every year. And if his cost of living increases, then what? I mean, we all have increases in our cost of living.
Well, that was the one of the things that we looked at. We think it needs to be based upon, what everybody else is getting.
Yeah, if his cost of living goes up, so does all the other employees. So if the other employees don't get one, it would not be equitable for the CEO to get one.
Mm-hmm.
Okay.
That was sort of our determination as to, we wanted to just get away from just that flat 5% no matter what, just an automatic increase. If you recall, Joel, and every other members on the board, when we started looking at his compensation from year to year, the objective was to get him at a standard where other CEOs and safety net hospitals were receiving. We think we have accomplished that. And we accomplished that through that 10%, that continuous 10% raise, it wasn't guaranteed, but it certainly allowed him to earn it.
So what did you find from your research on the safety net hospitals in terms of salaries that other CEOs were getting?
That we're in line with those.
Okay.
Of course, there's some that make more, but they're larger facilities. But
so based off of hospital beds?
They were based on beds, they're based on income, they're based on a lot of factors.
Okay. And then in regards to the 3-year contract, I know that Dr. Webb had requested a 5-year contract. What's the reservation with him getting a 5-year contract? Especially since we'll be in the middle of building a new hospital. Do you think it's wise to change leadership during?
Yeah, I think we discussed that and what the what the request was, but the committee, was very set on the 3 years as opposed to a 5-year contract.
So
I mean, we considered that, but based upon the discussion that the ad hoc committee had, we felt that 3 years was an adequate time for us to obligate the board based on the compensation that he's receiving.
do you think that it's wise to change leadership in the middle of building a new hospital?
I think that's something that certainly the board can, probably should consider. It's something that we talked about it, but again, majority rules. And I think we had actually had a unanimous decision after some discussion, because there was a proposal. There was a 5-year proposal, there was a 3-year proposal, there was a 3 + 1 + 1, which were, sort of option years, which would accomplish the 5 years, but it doesn't necessarily guarantee that we have the 5 years. But again, we can do any of those things. This is just a recommendation from this ad hoc committee.
Yeah, just in my honest opinion, I think a 3 + 1 + 1, because you also have the option after that 3rd year to decide whether or not you want to renew the contract for an additional year or so.
But I would add that if it's a 3-year contract and it comes up for renewal and he's doing a good job, then it shouldn't be an issue to renew for whatever the next term would be. So it's almost a moot point, because if you did a 3-1-1 and after 3 he wasn't doing a good job, then it would be, you'd still be in the same spot.
So it really wouldn't make a difference if we put a 3 + 1 + 1.
Well, but again, the contract, and you negotiate contracts, you want to make sure, people get what they, what they're asking for, at least, to try to negotiate something that both parties feel that are fair. Now, based on what was asked for, there may be some board members that feel that we need to think about this 5 years for stability purposes. But again, the recommendation that we're making is the 3 years. Of course, the board can do, whatever they want to, in reference to the approval or modifying what our recommendation is.
So I just want to make another point, which is more about the information I have on hand to think about this particular item. And I think Michelle Robertson probably raised that issue earlier. It's just that ahead of this meeting or the previous times this has come up on the agenda, I haven't really been able to go through any information. So I've been taking notes about the different numbers, like 426 or 479 or 553. And I just think it would help me personally just to be able to look at some information, for instance, even about the review with comparisons with peer hospitals. In the absence of that information, it's not entirely clear to me what I am basing my decision-making on. That's just more me sharing a predicament that I face in thinking about this particular item.
But again, to your point, that was the purpose of assigning a ad hoc committee to review those things and then come back with a recommendation, to the board. None of this is really out of line. We're not doing anything. He's already at the 479. The only thing that we're doing at this point is extending the terms of his contract and putting a 5% cap on what the incentive payment is going to be. Also, what he'll do in terms of incentives. So, we can go around and around and back and forth, but he's already where we're talking about. He is already there.
Well, first of all, Mr. Manson, I want to be very clear. I'm not for a minute even suggesting there is anything offline about this, and I appreciate the work of the subcommittee. I was just making a point saying that even a brief note summarizing this information, so I wasn't having to listen to it verbally, right, would probably help me. But that could just be me, so I would defer to the rest of the committee.
No, I got that. But again, I'm going to make you and I guess you get a sense from what we did. I mean, I guess we could have sent this out prior to the meeting, but you know, the work that we did, you know, and I think what the chair tried to do is get, you know, sort of a cross section of people on the board, you know, that we had finance, we had other folks on the, you know, on there that we're looking at and trying to make a determination of how we bring this to a closure. You know, again, our evaluation was he's already there. He's already at 479,000. Even if his request was 500,000, he's already there because he's 479 plus the 30%. So when we looked at it, we thought, and then when we compared it with what they're making at other hospitals, like the Safety Net Hospital in Memphis, that gentleman makes $900,000 a year, you know, sort of base. I don't know what the other compensation is. So, you know, we did look at all these things. If the full board needs to look at our minutes and make a determination of, you know, the information that we reviewed, we certainly don't have any problem with you doing that, quite frankly.
That was my understanding. They were going to y'all were going to bring a proposal to the board sent to us in advance so that we could vote on it in the next, whatever the next board meeting would be.
Okay, well, this is the report. So you're saying your understanding or the process we want to use is we make our report and then we vote on the next one at the next meeting?
Well, y'all, my understanding is y'all were going to prepare the information and then send it to the board in advance of the board meeting. So we had time to absorb it and formulate questions and look over the data to ensure that we're being equitable. Just like we've asked the same thing from the PSA committee. You need to get all that to us prior to the board meeting so that we can absorb it and read it. Any large contract, I think that's appropriate. So I think that's what Rhonga is asking.
Well, and I, you know what, I can appreciate that, but again, you know, when we looked at it, I mean, we can go back and forth and around, but it's if we want to, I'll submit to the entire board the 2 minutes, which are very detailed, and you can review that, and then we can vote on the recommendation, you know, at the next board meeting. The committee has no problem with that. We have met our responsibilities. Our responsibility was to make a recommendation.
Agreed.
We can't approve it. We can only recommend it.
Agreed.
So that, Madam Chair, that really completes my report if there are no other questions.
Okay, so if there's no questions, so we're just entertaining, we're not voting on anything, we're just going.
I'm providing this information I'm providing this report. This is a ad hoc committee report that I will provide as part of our minutes, which will include not only this set of minutes, but the previous set of minutes and the other information that we used in reference to how we evaluated and got to the decision that we made.
Okay, so you'll get that information to Janet, and then she'll send it out to the rest of the board.
I will do that, Madam Chairman.
I really appreciate that, Mr. Manson. Thank you.
Okay, no problem. Not at all.
Okay, so we'll now move on, since we're not voting, we'll move on to the CEO report. Dr. Webb, you have the floor.
Thank you, Madam Chair. Okay. I submitted to the board in the packet the CEO update. The first item was an update on the PSA agreement, and it stated that the last sentence stated that we're making progress towards an accommodation for both parties. As of today, we made an agreement with Meharry and along with the mediator and executed a 2-year contract extension for the PSA. So it is signed at this point.
That's great news, Dr. Webb. Glad to hear that.
Thank you. You have some other items on the CEO report. I just will point out that we also have begun now to receive quality incentive checks from our MCOs, the third-party payers, particularly one that we've engaged in for the first time. We've been working on this for a while. We can get to the point of where our HEDIS, which are quality measures, are being tracked, and incentive payments are made based on quality improvement outcomes of our patient population under those certain carriers. So we're starting to see some of that now start to develop, which reinforces the models that we have in place for driving quality and improving the quality of the overall patient population that we serve. So just wanted to update, give you a quick update on that, as well as the Commission on Cancer reaccreditation that occurred over the last few days, and we received 0 findings. So this program is an 80-year-old program that delivers excellent care in cancer care. So that was reflected in their report. Other than that, that's my update, my report. Happy to answer any questions that you might have.
Madam Chair, Dr. Webb, I still have a concern that these contracts aren't being brought before the board. I know we explicitly said over the past several years that any contract that's going to go before the PSA should be brought before the board before it's signed and approved. So I'm curious, how did I miss that process? Was the board addressed and was it sent to them for review prior to signing?
What, the PSA?
Yeah.
Oh, the PSA is simply a continuation.
Right, but that's making the assumption the board would have continued that. The board did not have the opportunity to review that document.
Okay.
And you were instructed to present it to the board prior to any signing.
Actually, there was nothing changed in the document.
That's not relevant. You executed another contract with them by extending that contract.
Now, Joe, I'm gonna take issue with that, because what we were instructed him to do was get that PSA signed, and we engaged a mediator. You can't sit with a mediator and say, well, let me check back with the board to see if they're going to agree to it. That's not the purpose of mediation. He had the authority to sign it.
I agree.
It's just the same, if the same terms and the condition of it, we're just extending it, then what's the point?
That was not our instructions.
We've never given them instructions. That, I think that may be your desire, but this board has never instructed them to be bringing every contract to us. We'd be here all night trying to review contracts.
No, I didn't say every contract. The PSA in particular was asked to be brought to us before it was signed for board approval.
I don't ever remember that, and I'd have to see the minutes that said that. I don't think there's a minute.
Well,
I don't think there's a minute that said that.
Well, it's duly noted. So I'm concerned about that because we had that issue last month that News Channel 5 brought up.
Well,
we knew nothing
I have
about.
that concern, and I think perhaps some board members or some people are trying to raise those concerns, unnecessarily. But I think we got to be really careful about the things that we're saying, and if it's not in the record, then I don't think we can go outside the record and say, well, this is what I hope would happen, or this was my desire that it would happen. We instructed, my recollection is that we instructed that this PSA needed to be signed, and that we engaged a mediator, not only once, but we engaged a mediator twice to bring this to closure. And now that it's closed, now we're trying to go back and say, well, we don't want to close, we wanted to see it before it was done.
Yeah,
now-
Richard, can I jump in for a minute? This is Dr. Burley.
Yeah, Burley.
And I just wanted to say, since I've been around here probably the longest listening about the PSA, and I actually think this was the third mediation in terms of trying to get this done. And I do remember that going back to Dr. Webb's last contract renewal, that the biggest goal he was given was to get the PSA signed. And that's why it was tied into his future compensation. Everything was about getting that signed. And I think back to all the meetings that we've discussed this and the role of the mediator. The frustration was that the mediator couldn't get anything accomplished. So I guess I'm having a hard time saying that that actually Dr. Webb finally got done what we've been trying to do for a number of years. And if it was okay through the process of the mediation, I guess I'm not sure that, and if it's the same contract, I'm not sure if we would have had any objections to that. You know, just looking at it, I mean, he could have brought it before the board, but if it was just an extension, I think the goal was to finally get something in place, and he's done that. So, you know, I'm not sure, you know, if it would have changed anything, whether it came to the board or not.
So it must be my misunderstanding, but I think a contract as substantial as this, or any contract as substantial as this, should be brought before the board for, if nothing else, informational purposes, because we are responsible for this organization.
Well, I think that's what you desire. That's not what just because you desire that to happen doesn't necessarily mean that has to happen that way. What I'm suggesting to the entire board is that we have struggled with this PSA under a number of chairs and a number of board members, and it's always back and forth in reference to this contract being approved, and this board does not run this hospital. We oversee the operations of what this CEO and whatever their staff has done. We're a policy board. We're not trying to run this facility. And when we start getting into reviewing contracts, whether it's for $50,000 or $100, there are $1 million contracts that we're probably not reviewing, you know, that are in place. So, you know, I just think and I respect what you're saying, Joel, but at the same time, I don't want to put us in a position where we are managing a hospital, because that is not what I don't think any of the board members kind of signed up for. That's that's what my statement is.
I'm in agreement with you there. I just think it's incumbent upon the hospital board to understand our large, substantial material contracts. And you're right. We did instruct Dr. Webb to go work with a mediator to get this done, and I'm excited that it's done. My only concern is a matter of order for contract review, and I certainly don't want to review every single contract. You are correct there.
Yeah.
Okay, so I think we can agree that we are happy that the PSA has been signed.
No, I think we can agree that we're elated that the PSA is signed.
Exactly.
You have to understand what, you know, Joel, you and I both been on this board for a long time, and this was like a mess. And it was back and forth. You and I both have been engaged in this, you know, this discussion, and we continue to be engaged in this discussion. But, you know, we had to move this thing forward in order for us to be able to do what we needed to do to preserve the integrity of this hospital and the operation of it. So I don't think we need to just, you know, we should be really celebrating the fact that we've accomplished that. Not only that, but we should be celebrating the fact that we've got a 80-year-old facility, 80-year-old program that's operated here in, you know, dealing with a serious disease, and that we become accredited for it. So I don't want us to, you know, I know we've been talking about salaries and compensation and all that, but at some point we have to think about what's going to be in the best interest of our patients. I'm excited about it. Joe and I, when we first got on this board together, was like, why can't you get this signed? Why can't we get this done? And I think everything was done to try to do that. So Dr. Webb, you know, we congratulate you
Madam Chair,
Yes.
Stevenson here. I just wanted to reflect on a comment that was made for a point of clarification. Specifically, since the contracts are reviewed through the Finance Committee, our board member Sullivan suggested that News Channel 5 covered some information about a contract that he was surprised about. And I want to just make sure everybody's clear that just because News Channel 5 covers about information of contracts we're reviewing doesn't make it a bad contract, even if they think so. To cast aspersion and to continue this systemic racism on every time a vendor steps up that they don't care about is ridiculous. And so I just want to make sure we're very clear that these were contracts that are under review. They're still being reviewed. The Finance Committee has taken action on some, and we've made some other recommendations. But I don't want the narrative to be that simply because Channel 5 shared some information and skewed that information, that means that those are bad contracts or services that are needed, that are not needed for this population. Those are services that are important to this population. And so I just wanted to have a point of clarification, and I appreciate the chair giving me that opportunity.
Thank you for stating that, Reverend Stevenson. And we all know we can't believe everything we hear in the news. All right, so I don't have anything to report. So we'll move on to the public comments. Are there any public comments? All right, well, without any further ado, hearing no further opportunities for discussion, I will entertain a motion and a second for adjournment.
So moved, Ranga.
Thank you. All ayes.
Ayes.
Burley,
Hold on.
We're doing the roll.
Aye.
Fagans,
Aye.
Fisher, I'm sorry, Manson,
Aye.
Ranga,
Aye.
Robertson,
Aye.
Stevenson,
Aye.
and Sullivan.
Aye.
Thank you.
All right, hearing no abstentions or nays, the motion carries and we are adjourned. Thank you, everyone. Have a good weekend and good night.